acute thrombotic event from COVID-19 infection, short-term follow-up. And I'll be very interested in this as well. It's a kind of a sign of the times. Presented by Chris Faries on behalf of his group from the Mount Sinai School of Medicine in New York.
Hello, my name is Christopher Faries. I'm a third-year medical student at the Icahn School of Medicine at Mount Sinai, and today I'm going to be presenting on acute thrombotic events from COVID-19 infection and their short-term follow-up. I have no disclosures. So COVID-19 is an infectious disease caused by a novel coronavirus. Has a wide variety of recognized presentations from asymptomatic carriers to upper respiratory symptoms. There's increasing evidence that COVID-19 results in a hypercoagulable state with subsequent arterial and venous thrombotic events. And we described the 1-month follow-up of 30 patients who presented to our health system with COVID-19 and a concurrent acute vascular event. Data was prospectively collected and maintained for all vascular surgery consults in the Mount Sinai Health System. 30 patients in our database experienced an acute thrombotic event and concurrent COVID-19 infection confirmed by PCR testing from March 16th to May 5th of 2020. Our primary outcome was clinical patency, defined as freedom from claudication and rest pain after intervention. Secondary outcomes included mortality, length of stay, and morbidity. 25 patients experienced arterial thrombotic events and 5 experienced venous thrombotic events. Average age was 64.8 years old, and 33.3% of patients were female. 70% of patients had hypertension, 40% had hyperlipidemia, 33% had peripheral vascular disease, 43% had diabetes, 10% had chronic kidney injury, 23% had coronary artery disease, and 26.6% were obese. The admission indication was acute thrombotic event for 73.3% of our patients and was COVID-19 for 23.3% of the patients. One patient was admitted for hypertension. Moderate COVID severity on admission, defined as an oxygen saturation of less than 94% on room air or radiographic evidence of pneumonia, was significantly associated with arterial thrombotic events, and severe COVID-19 on admission, defined as requiring oxygen escalation greater than nasal cannula to maintain O2 saturation, was significantly associated with venous thrombotic events as compared to arterial events. Interventions that patients received included 2 minor amputations, 6 major amputations, 11 open surgical bypasses or surgical embolectomies, 7 percutaneous angioplasties or venoplasties, and 10 patients were treated with conservative medical therapy. Complications seen upon 1-month follow-up included 6 total readmissions, with 5 of them being unplanned, 2 deep vein thromboses, 4 hemorrhagic complications, 6 wound infections, 2 MIs, 3 major amputations, 4 acute kidney injuries, 2 strokes, and 1 patient had to be reintubated. On 1-month follow-up, the average length of stay was 9.9 days. 8 patients had expired upon 1 month, and the mortality rate was 26.67%, with 32% for the arterial patients and 0% for venous patients. Causes of death included pneumonia in 4 patients, multi-system organ failure from sepsis in 1 patient, and cardiac arrest in 3 patients. The total rate of limb loss upon 1-month follow-up was 30%, and the 1-month clinical patency rate was 70%, 62.5% in arterial patients and 100% in venous patients. So in conclusion, patients with acute COVID-19 infections who experienced thrombotic events saw poor outcomes at 1-month follow-up, and in particular, there were high rates of mortality and limb loss and low patency rates. Thank you very much.
Thank you very much for that talk. While we're waiting for some questions from the floor, I've got a couple of my own. First off, I think, how did you guys capture all these patients? I guess my biggest question is that, only 5 or 15% of your events were venous. Was it an analysis of the entire healthcare system, or just stuff that came to the vascular surgeons or your division specifically?
Yeah, so they were all consults from the vascular department at Sinai. That actually highlights one of the major limitations of the study, specifically with the venous thrombotic events. isn't exactly representative of the total amount of patients with venous thrombotic events and COVID-19, as obviously that number is far greater, but these were just the patients that were required consult or vascular management.
I see. Do you guys have an idea of whether or not there might be more of these scattered around? Because I personally would have just expected a higher rate of venous thromboembolism in COVID. And I'm wondering if that was part of what kind of kicked your rate of this venous thromboembolism, specifically in very severe patients.
Mm-hmm. Yeah, so there were, I mean, I don't have the numbers because I don't have the complete data set from all patients with COVID in the hospital, but yeah, there were many more anecdotally. As to the severe presentation, there's a couple different possibilities. One could just be that more severe patients required vascular management, and another could be that, conditions associated with like DVTs, for example, like would be more likely to seen in a patient with severe COVID, like if they're intubated and unable to move and sedated for an extended period of time, then their stasis will make it more likely for them to have a venous thrombosis.
Right. Do you know how many of these arterial thromboses had previous interventions? Because I've personally had a couple patients over here in Pittsburgh that have come in with either thrombose bypasses or thrombose stents that had active COVID, rather than in addition to kind of the native thrombosis.
Yeah, so I don't have the number for patients that actually had previous intervention. The patients with previous peripheral vascular disease there were 10 of them, so 33%. But there were, just from what I had seen in the charts, several that had previous like stents, for example.
I see. Question from the floor from Dr. Kim. Did any patients experience both arterial and venous events?
Yeah, one patient experienced a venous event that later experienced an arterial thrombotic event. Yeah.
I see. And a question from Dr. Smeds. Did you guys see any difference in the care provided at that time versus what you would normally do in a non-COVID period? Was there less access to the intervention suite or the OR, or longer delays of treatment because of the healthcare stress? And could you associate that with the bad outcomes? This may be kind of an anecdotal answer.
Yeah, just from what this is a chart review basically, but from what I'd read, there were several longer term minor complications beyond 1 month, because we've continued to look at these patients. For example, a couple of patients experienced ischemic neuropathy later on because they were unable to be intervened on during the acute sort of height of COVID during the fall due to non-elective procedures being canceled. Elective procedures being canceled, sorry.
Right. Another question from the floor from Dr. Blazik. Did you look at time from diagnosis of COVID-19 to the thrombotic event, particularly in venous thrombotic events? Were thrombotic events ever the inciting clinical feature?
Yes. So for venous thrombotic events, well, first of all, we didn't look at the time in between from presentation to event, but I mentioned in the presentation the admissions indications, which were 22 of the admission indication were actually an acute thrombotic event like acute limb ischemia or acute on chronic limb ischemia, and only 23% were admitted for symptoms of the actual or pulmonary symptoms or other complications of the COVID-19 infection.
I see. And a question from Dr. Nelson: were venous thrombotic events primarily managed by a different department or division? Is it just whoever was managing the patient at the time took care of it?
That's my assumption. I don't have the data for the rest of the patients with venous thrombotic events, but yes, they were not managed by vascular.
I see. Yeah, interesting results for interesting times. So thank you very much.